Regarding safety, I have a question for Professor Yuan Peng. And in advanced stage, if you use this as a rescue therapy, is the safety in line with that patient profile? Then, should we treat patients with the TDM1 for 14 cycles? And for TDM1, they may explore the possibility of 8, 4, 6 cycles of TDM1. So, Professor Yuan, for the intensified adjuvant therapy, if we covered risks that are remain there after dual chemo, dual targeting therapy, should we go for 14 cycles maximum? So, Professor Yuan. Thank you, Professor Junjie, for your question. DB05 and DB11 studies will give us new directions, especially in the guidelines or in the strategies. In DB05, we've found 3-year IDFS data that is so great. And we may be prone to look at better efficacy of patients, because for early breast cancer patients, either NAT or AT would like to bring cure to patients, and that is a very important goal. Side effects are considered, and they are important. In the study, TDXD arm had 2 cases of death, 5 patients in TDM group died, and among them, during the therapy, this happened. For the TDM1 cases, there are some other cancer patients, like fibroma or sarcoma or whatever. So I'd like to consult Professor Geyer. Are these deaths related to the study drug? And but they are like sarcoma or fibroma, especially in the TDM1 arm. So why? Question number 1. Question number 2. For advanced patients, if we can treat patients for 14 cycles, few could make it there. For TDXD, side effects like in GI, it's kind of serious. For majority of advanced patients, if they take TDXD, will add olanzapine. It is a quadruple anti-emetic therapy. There are other side effects like fatigue. We don't have good therapies to treat fatigue. So patients, due to such side effects, give it up. And we'd like to increase interval or reduce the dose to make sure they are adherent. So for advanced patients, this is in line with the expectation. For advanced patients, they like to prolong their survival, but they don't do well in general. In terms of sustaining the therapy, this is not ideal for the advanced patients. For DB09, there was PFS at 40 months, and we even doubt for real patients if they are on TDXD, will it be that long? Then, furthermore, if the patients take 14 cycles of TDXD, is that necessary? For adjuvant therapy, for patients who are not achieving PCR, we choose TDM1 as the first choice. TDM1 doesn't bring good tolerance at all. So, more often than not, if there is a second thrombocytopenia degree 3, I recommend not using TDM1 because some patients will have sustained degree 4 thrombocytopenia. And if the patient lasts TDM1 for 14 cycles, it's rare. We'll go for HP after TDM1. So, is that feasible to achieve 14 cycles with TDXD? This is something we need to consider. You know what? For DB05, we see Chinese population among the total subjects. what was the safety profile? Can we have a subgroup analysis for Chinese subjects? For Chinese people, bone marrow, liver function are different from the Caucasian population. For TDM1 studies, they have good tolerability with the TDM1, but not necessarily for Chinese subjects. The tolerability in Chinese population is not as good as what is shown on average in Catherine's study. So is that possible to have some subgroup analysis for Chinese population? Thank you. Thank you, Professor Yuan. Let's go on. You know, I paid attention to details. ER negative and HER2 positive, there is early PCR. And, so under such data, I checked the data, 2/3 have positivity. The HR values are different. For ER positive, HR 0.54, negative 0.37. So, Professor Wang Yongsheng, for the ER status, will that be a very important indicator for your choose NAT or AT in terms of MOA? For ER negative, TDXD may not even do much better than TDM1. How do you put that to perspective? Right. So Professor have compared this DB05 versus Catherine study. TDXD versus TDM1. This is a head-to-head comparison. Though the DB05 includes high-risk population. So we don't have to look at Catherine's study anymore because unless this is not comparing TDXD versus TDM1. With this DB05, whatever the ER, whether it's HC 3+, 2+ is, or whatever, in general, if you look at efficacy, TDXD is doing better than TDM1. In general, whether it's ER positive or negative, I would like to choose TDXD as an intensified adjuvant therapy. Of course, you mentioned side effects. If the patient cannot tolerate that, if they cannot tolerate TDXD in adjuvant setting, we may go to TDM1 to have a sequential intensified therapy. Whether it's positive or negative, the first choice of mine could be TDXD when this is approved in China and when this is reimbursed. For sure, I think this will be a preferred regimen. Over to you, Junjie. Thank you, Professor Wang. I agree with your points. All patients who are indicated should be treated with the TDXD preferably. Professor Wang mentioned subgroups. I'd like to ask Professor Geyer.
About 15 or 16% of the patients, they are HER2 2+ and FISH positive. And in the subgroup analysis, we don't have the data of whether these HER2 2+ patients, they are more sensitive to the TDXD. So any comments or any data about that? Do you believe that in the HER2 2 positive and maybe the HR is more beautiful, 0.2 point or any other data? Yeah.
Yeah, I mean, the HER2 2+ group clearly was another unmet need out of Catherine. It was interesting, though, that's a tougher subset to call out on a regulatory sense. So it wasn't listed as a target in the trial, but we clearly are interested in that. And we actually are going to be reporting that at San Antonio. We had just seen the data. We didn't have time to get through anything beyond the main analyses. So we do have that. I have seen it and I can't tell you what it shows, but I think you'll be pleased with what you see. Basically, that I think it is important. And for me, I think this is the really exciting thing about having multiple agents. I mean, I hear sometimes say, oh, we've replaced TDM1. well, have we? I mean, do we have it's an active drug. Catherine showed it to be very active. It's just that TDXD is more active in more patients. As we get more into individualized care, nuances, are we sure that we're going to cast it aside? Like with chemotherapy, we had what anthracycline was our best, and then Taxol was behind it. We didn't throw them away. We looked at combinations using things together. And I think a real challenge for me is that PCR is a great endpoint when you get to it, particularly if you start out with smaller volume disease, minimal nodal disease, but even a high-risk patient who has a PCR, GBG showed us they've still got a 1 in 5 chance of recurring. So the PCR, it's better than not having a PCR, but if you've got a 20% chance of recurrence, and for me, I really am curious how, as our ctDNA technology is improving, are we going to be able to bring that in and help be more nuanced? I don't think we're going to see PCR go away, but do we use PCR and MRD to help us assess and guide therapies and move from a treatment that's not working to another one? I think it's going to be a very interesting time, and I've been impressed by the work at Fudan on this molecular understanding, going to subsets. I think that's a really exciting design, that trial that is being launched in China. I think this is where we all need to go. So I congratulate you on that.